Hello guys, this is Dr. Massman here, and today we will study anatomy. And first chapter we will study is neuroanatomy. In neuroanatomy, we have nervous system which is divided into two, CNS and PNS. CNS is the one which is divided into two, brain and spinal cord. PNS is the one which is divided into two, cranial nerve and spinal nerve. Okay, in cranial nerve we have 12 pairs, in spinal nerve we have 31 pairs, right? Now we have five things: cervical, thoracic, lumbar, sacral and coccygeal. Cervical we have 8 pairs, thoracic we have 12 pairs, lumbar we have 5 pairs, sacral we have 5 pairs and coccygeal we have 1 pair, right? Now let's come to brain, which is also called as encephalon. Okay, first of all, when we see a sagittal section, we have three things: forebrain, midbrain and hindbrain, right? Forebrain is also called as prosencephalon, midbrain is also called as mesencephalon, hindbrain is also called as rhomencephalon, right? Now, midbrain is the one which is not divided, right? Now, what do we have here is in forebrain, okay, we have two things. We have cerebrum, also it is also called as telencephalon, plus we have diencephalon, which is also called as thalami. So this is there in the forebrain, right? Then in the hindbrain, what do we have? We have pons, we have cerebellum, and we have medulla, right? Pons and cerebellum together called as metencephalon, and medulla it is called as myelencephalon, right? And then we have spinal cord. Okay, so these were the things about sagittal section of the brain. Now it comes the coronal section. So whenever we see the coronal section of the brain, we have ventricles. Okay, so in the ventricles, what do we have is we have lateral ventricle, okay, which is 2. Then we have third ventricle, which we call as diencephalon, and then we have fourth ventricle, which is also called as rhomencephalon, right? So from the lateral ventricle, we have choroid plexus. Okay, from there it goes through a foramen of Monro. Okay, then it comes to midbrain. In midbrain, what do we have? We have aqueduct of Sylvius or cerebral aqueduct. Okay, then comes down. Then in the fourth ventricle, we have two things. First is foramen of Lashka and foramen of Magendie, right? In Lashka means lateral and Magendie is middle one, right? So this is there in subarachnoid space, right? Then we have hydrocephalus. In hydrocephalus, it is the one which has increasing CSF. Okay, in this it has two things: communicating and non-communicating. In communicating, there is no blockage. Okay, in non-communicating, there is blockage in the ventricular system. Okay, usually in aqueductal stenosis, third ventricle is enlarged. Okay, now we will move one by one. First will be spinal cord, then we will talk about midbrain, pons, medulla, which will be hindbrain, and then we will talk about cerebellum, then we will talk about cerebrum. Okay, gray matter and white matter. So first is the spinal cord. In spinal cord, first let's talk about the external features. In external features, we have adult. In adult, it moves towards C1 to L1. L1 is the lower border. Then in the neonates, it will be from C1 to L3. L3 will be the upper border, right? So in adult, it is L1, which is lower border, and in neonates, it is L3, which is upper border, right? Length in male 45, female it is 42. Shape is cylindrical. Then we have two enlargements, cervical and lumbar enlargement. Okay, then we have two things. In this we have, first of all, we have L1. Okay, and from there then it goes to L3 and L4, then it's S2, right? So in L1, spine ends at L1. Okay, and then lumbar puncture we do it at L3 and L4. Then S2 is the subarachnoid space end at S2, right? So this is what the thing is, and it is the lower border, right? And then we have conus medullaris, which is a cone-shaped structure. Okay, and at the end it will go to phylum terminale, which is a continuation of the pia mater. Okay, and then coccyx. Okay, so now let's talk about the layers. In the layers, first we have skin, then supraspinal ligament, then interspinal ligament, then we have ligamentum flavum, then we have epidural space, dura mater, arachnoid space, and then subarachnoid space, right? Okay, now let's see the modifications of pia mater. We have phylum terminale, linea splendens, and ligamentum denticulum, right? So in this we have post-median sulcus, anterior median fissure. Okay, and then we have extension of pia mater. Okay, and in this, when we see, there will be tooth-like projection, which is also called as ligamentum denticulatum, that will be right and left with 41 projection on each side, right? So then comes chorda equina, which is also called as horse tail. It will be like L2, L3, L4, L5, like this it will be there, okay? Then we have transverse section of spinal cord. In this, there will be on the left side, there will be dorsal horn, then ventral horn, then lateral column. Then on the upper side, there will be dorsal column and posterior median sulcus. On the right side, we see it will be sensory or efferent, or then center canal, and then motor or efferent, okay? And the downside, we see it will be ventral column or anterior median fissure. So in brainstem, what do we have is midbrain, pons, and medulla. Okay. So what do we call as cerebellar peduncles? Okay, pons and cerebellum. They both together called as cerebellar peduncles. That will be superior, middle, and inferior. Okay. Then we have ventral aspect of midbrain. In this, there will be nucleus ambiguous. First of all, let's start from the beginning. We have cranial nerve number 3, 4, 5, 6, 7, 8, okay, then 9, 10, 11, and 12. Like this we have, okay. So let's talk about the fourth one. First of all, okay, let me tell you what is nucleus ambiguous. 9, 10, and 11 nerve together called as nucleus ambiguous, right? Then for 1, 2, and 3, this we know. First is olfactory, second optic, third is oculomotor, then comes fourth is trochlear one. So about trochlear, it is the smallest, slendermost. It is dorsal origin. Okay, it is the longest intracranial course. It is internal decussation crossing inside the midbrain. Okay, then comes fifth nerve. Fifth is the largest and thickest, and it exists between pons and middle cerebellar peduncle. Okay, then comes sixth one. Sixth is the one which is the most common involved in ICP, intracranial pressure, and these all three, 6, 7, and 8, all three are there in the pontomedullary junction, and it is the longest interdural course. Okay, then is the seventh one. Seventh is facial. Facial is the longest intraosseous course. Okay, then we have eighth is vestibulocochlear. Okay, then we have 9, 10, and 11. 9 is glossopharyngeal, vagus, and accessory. These all three of them are lateral to olive, and between pyramid and olive will be the 12th one, right? So this is how we can see. So three of them are lateral, and between two of them will be the 12th nerve, right? Pyramid and olive. Then we have interpeduncular fossa. In this we have optic chiasma, optic tract, and then we have cerebellar peduncles. Then we have infundibulum, mammillary body. Like this we will have. And let's talk about the contents of interpeduncular fossa. Okay, in this it will be infundibulum, mammillary body, posterior perforated substance, and cranial nerve number 3. And then we have optic. So this all four I have talked, and we can see in the structure optic chiasma, optic tract, and cerebellar peduncles, right? Okay, now let's see the dorsal aspect of midbrain. In the dorsal aspect, what we can see is first we can see colliculus. Superior colliculus, inferior colliculus. Superior for the visual, inferior for the auditory. Then we have corpora quadrigemina, and then we have fourth nerve. Okay, and in this, then we can see in the dorsal aspect, it is the floor of fourth ventricle or rhomboid fossa. In this, it will be facial colliculus, which will be due to sixth nucleus. Then we have vestibular area. It will be due to 8th nucleus, hypoglossal triangle, 12th nucleus. Then we have vagal triangle, which is due to 10th nucleus, right? So the important one is the facial nucleus, which is due to facial colliculus due to 6th nucleus, right? Okay, now let's talk about the facial. In this, first what we have to see is facial colliculus. Why? Because it is the one which is surrounded by the 6th nerve. Okay, due to 6th nucleus. So that's why it is more important. So it's behind the point, 7th nerve taking turn around 6th one. Okay, and then we have to note that facial colliculus leads to paralysis of muscle of facial expressions. And then we can see, like in the diagram, midbrain, pons, medulla, behind will be cerebellum. Then we have fourth nerve. Like this we can see. Then transverse section of midbrain. In midbrain, what do we have is we have three things: tectum, tegmentum, and cerebellar peduncles. Okay. Then in the tectum part, what do we can see is corpora quadrigemina. Okay. In tegmentum part, what we can see is red nucleus. Okay. And cerebellar peduncle, what we can see is crus cerebri, which is white matter. And also in the cerebral peduncle, we can see the substantia nigra, which is the gray matter, right? And about the third and fourth nerve will be seen at the level of superior colliculus, and fourth nerve seen at inferior colliculus, right? Then we have transverse section of pons. In the pons also we can see the same thing which I told. Facial colliculus we have to see, which is taking round, okay, at the sixth nucleus, okay. And then we can see a transverse section of medulla. In medulla, what we can see is we have olive and pyramid. Olive is due to inferior olivary nerve. Pyramid is due to pyramidal tract. Then we have 12th nerve. 12th is the one which is between both of them, right? Then we can see white matter. White matter is bundle of axon in CNS. Okay, in this CNS, what we can see is we have white matter and gray matter. Yes. So white matter. So in this, like we were talking about axons in the CNS. So we have two things: gray matter and white matter. Okay. In white matter, we have three things: association fibers, commissural fibers, projection fibers. In gray matter, we have two things: central cortex and basal ganglia, right? So association fibers means what? It means that it connects different lobes in same hemisphere, like fronto, parieto, temporal, occipital. Same lobes in different hemisphere, right? Then we have commissural fiber. Commissural fiber means connect same lobes in different hemisphere. For example, left and right. That is commissural fiber. So association was frontal, parietal, temporal, occipital. Commissure was left to right, right? Then we have projection fibers. Connects functional area of brain with spinal cord. So brain to spinal cord, that is the projection fibers, right? Then you have gray matter. It is collection of what? Cell bodies, right? And white matter, that was collection of axons, right? So in gray matter, cell bodies are collected. It has two things: central cortex and basal ganglia, right? Okay. So now let's start with the fibers. First one was association fibers, like I told, fronto, parietal, temporal, occipital. In this, it has two things: short and long, right? In short, we have gyrus and sulcus, and in this we have fasciculus, that is arcuate fasciculus, right? Okay. And then we have long. In long, we have four things. First is what? Superior longitudinal fasciculus. Okay. Then inferior longitudinal fasciculus. Then we have third is uncinate fasciculus. Then fourth we have cingulum. Okay. Now in this we will find two things. First will be Broca's area, that will be speaking, and then it will be 44 and 45, which is a Broca's area, and then we have two things are 41 and 42, that will be for auditory area, and uncinate will be the one between them, uncinate fasciculus, right? So we have to note one thing, that is Broca's area, which is 44 and 45. It is connected to auditory area, which is 40 and 42 by what? Uncinate fasciculus. And then Broca's area, okay, which is 44 and 45. This is connected to Wernicke's speech area, that is maybe 22, 39, 40, whatever. It will be by what? Articulate fasciculus. So this question has come, right? Uncinate fasciculus and arcuate fasciculus. Okay. Now we have commissural fibers. So regarding commissural fibers, what I said was it connects same lobes but different hemisphere. For example, left to right, right? So in this we will have five things: corpus callosum, anterior commissure, posterior commissure. Then we have habernular commissure. Then we have hippocampus commissure, right? So we have we are seeing the diagram right now. In this, what we will see first? Rostrum, genu, body, and splenium. Okay. Now, when we see the anterior part, it will have anterior commissure. Okay, which will be below the rostrum. And then when we go posterior side, what we will see? First, we will see the pineal gland. Okay, we will have a pineal gland which is below the splenium. Okay. Now above the pineal gland will be habernular commissure, and below the pineal gland will be posterior commissure. So anterior commissure, pineal gland, habernular commissure, posterior commissure. Okay. Now below the body will be what? Below the body will be hippocampal commissure, right? Okay. So we have done this. Now let's see what is corpus callosum, right? Corpus callosum, this is the one which is the largest, and it has four parts which I told about: rostrum, genu, body, and splenium. So this was the corpus callosum. Okay. Now let's see what is this limbic system. In this limbic system, it is the one from which fornix begins from hippocampus? Okay, this will be the first question. Like first we have hippocampus, fornix, then mammillary body. So fornix begins from the hippocampus, and the second thing is hippocampal commissure. This connects the fornix, right? I am telling you again, hippocampal commissure connects two fornix. So like we have one fornix and two fornix. Two fornix are there. So it is connected by what? Hippocampal commissure. But the fornix, this is beginning from hippocampus. Okay. Now we go ahead. Then we have forceps minor, forceps major, and in between we have body. Okay, which is tapetum, right? And okay, so now we see the projection fibers. In projection fiber, which I told was brain with spinal cord, which is connecting. Okay, right? So in this we have corona radiata, internal capsule, and we have tracts, ascending and descending tract, right? So first we talk about the descending tract. Descending, what we call as motor tract, right? So in the descending tract, what do we have is we have lateral and anterior, right? So in the pyramidal tract or corticospinal tract, we have lateral corticospinal tract and anterior corticospinal tract. We have two things. In this, it will be motor function and skill voluntary movement. These two things will be there, right? And then comes ascending tract. In the ascending tract, what do we have? We have two things. First, we will have first we have is fasciculus gracilis, fasciculus cuneatus. Two things are there, gracilis and cuneatus. In this, there will be 4 to 5 things. First will be fine touch, okay, vibration, stereognosis. When I close the eye, in order to identify the object, stereognosis, then we have proprioception. Our limbs are there, right? So in gracilis and cuneatus, we have 4 things: fine touch, vibration, stereognosis, and proprioception. Then we have 2 things: lateral and anterior, okay? But there it was in the descending tract, it was corticospinal tract because it was descending tract. But now what will we have is we have ascending tract. So ascending tract is where we have to reach. We have to reach spinal cord, right? So it will be lateral and anterior spinothalamic tract, right? So in the lateral means lat. Lat means if you put lat to any person, what you will see, you will get pain and temperature. That person will get pain, his temperature will be risen, okay? And whenever it will be anterior, anterior means what? You can say maybe ant, okay, which is anterior. So in this anterior touch, what it will be? It will be crude touch plus pressure, okay? So in gracilis and cuneatus, it was fine touch. Here it will be crude touch, right? So this is what we have done about ascending tract. Okay, now let's go to pyramidal tract, which is corticospinal tract, right? In this, what we see motor area, somatosensory area. Okay, we have 4-6 motor area, somatosensory 3-1-2. Okay, so what we have here is first we have 2 fibers. Okay, first we have anterior corticospinal, and then we have lateral corticospinal tract. Okay, so what I told was corticospinal is the one which is the descending tract, right? So what will be here is in this, it will be like radiations are coming from pyramidal tract. Okay, 4-6 and 3-1-2, which I told, pyramidal area and all, they will come and they will cross, and they will cross to 2 things. It will be first either anterior corticospinal or lateral corticospinal. So when it will be crossed, so it will form 80 to 85, 95, 85 to 90% crossed. It will be at the lateral point, and 10 to 15 will be at anterior point. Okay, but that the place where it will cross, that is called as pyramidal desiccation, and that will be at the lower medulla, right? Now let's see the clinical correlation. In this, if it is before the desiccation, then it's contralateral hemiplegia, okay, before the desiccation. But whenever it's after the desiccation, it will be ipsilateral hemiplegia, which we also called as Brown-Sequard syndrome. Okay, before desiccation, contralateral hemiplegia; after desiccation, ipsilateral hemiplegia, Brown-Sequard syndrome. Okay, so that was about the pyramidal tract or corticospinal. Now we are talking about spinothalamic tract. Okay, thalamus. So it has to reach above. So in this, what we have to see is, in this what we saw was pain, temperature. It was there. You remember? I told right now. Okay, pain, temperature. It will be there. Crude touch, pressure. It will also be there. So it will go. Okay, through what? There is dorsal root ganglion. Through this, it will go, and also in this there will be substantial gelatinosa. Right? Through this, this will go upward. It will also have 2 things. Either it will be anterior, or it will be lateral. Right? So whenever you see it is anterior, so in the anterior spinothalamic tract, it will be what? It will be, this joins the medial lemniscus, okay, which doesn't form. Okay, it just forms medial lemniscus, but the lateral one, okay, lateral one, this will go up through the spinal lemniscus, okay, and as soon as it enter the midbrain, and this will enter and it will go to SSA, right? So that's how it will go. So this was the spinothalamic. Now let's talk about dorsal column tract, okay, which was medial lemniscus. In this, we will have two things, UL, LL. Two things we know, okay. Just make USC, okay, and it will be FC, okay, fasciculus gracilis, okay, and then LL will be FG, okay. So like this, it will go up, okay, and it will go through what? It will go through medial lemniscus, okay. Also, so this is what, but just you need to remember the main thing. It will be like whenever it's fascicular gracilis, it will be UL. Whenever it's FC, it's UL. Whenever it's FG, it will be LL. Only two things you need to remember, right? Then comes Brown-Sequard syndrome. In this, it will be ipsilateral. In this ipsilateral, which will be below the less iron, okay, and contralateral loss, it will be pain and temperature, right? This was the thing. Then we have yeah. Then let's go ahead and let's see the other structures. You can see like angular gyrus, supramarginal gyrus. You can see the structure of corpus callosum and also paracentral lobule. It's the center which controls urinary and defecation and represent perineum and lower limb. So this is also a good question. Perineum and lower limb. Okay, then we have is basal ganglia. In basal ganglia, what do we have is three things: corpus striatum, subthalamic, and substantia nigra, right? So in basal ganglia, this question has come in corpus striatum, which is also called a T-lencephalon, right? It has caudate nucleus and lentiform nucleus. So in lentiform nucleus, we have two things, putamen and globus pallidus, right? Then we have subthalamic nucleus. Then we have substantia nigra, and subthalamic is diencephalon and nigra is mesencephalon. Internal capsule, we have 5 parts: anterior limb, posterior limb, genu, retrolentiform and sublentiform, right? So the main thing is which one is lateral, which one is medium. Whenever you have lateral, okay, for example, okay, first let's talk about all. We have anterior limb, genu, posterior limb, okay, then retrolentiform and sublentiform. So in this, their lateral will be the one that will be lentiform nucleus, okay. This is the one which will be lateral, and medial will be two, caudate nucleus and thalamus, okay. So these are the relations. Caudate nucleus and thalamus will be the one which will be medially, and lentiform is the one which will be laterally, okay. So now in this, whenever we have genu, in the genu it will be about cortical nuclear tract. This question has already come, okay. Anterior limb and genu. In genu we have cortical nuclear tract, okay. And when you go to PL, right? PL is posterior limb. In posterior limb it will be cortico-spinal tract, okay. So nuclear one, in genu it was nuclear tract. In posterior limb it will be cortico-spinal tract, which will be anterior 2/3 of posterior limb, right? So this was the thing. And then you can see like from you can say like lentiform nucleus, it will be auditory relations, okay. In retro one, it will be like light music, visually cortex, all these things you can see. Now comes the main part, blood supply of brain. In this you will have three things: vertebral, branches of vertebral, ICA and basilar. So first let's talk about what is circle of Willis. It will be 5 things. First will be PCA, posterior communicating artery, okay. Then it will be posterior commissure, okay. Then you will have ICA, internal carotid artery. Then you will have ACA, and then you will have antecommissure. Again, PCA, posterior commissure, ICA, ACA, okay, and then antecommissure. These are 5 things which will form. Now let's come to the artery. So we will have first vertebral artery, ICA, and then basilar artery. In vertebral artery, what do we have? We have anterior spinal and posterior spinal, okay. Anterior spinal artery and posterior spinal artery, 2 things which is at the spine, right? Then it will be medullary branches, okay. We will see medulla, anterior spinal, posterior. Then we have medullary branches which we can see at the medulla, and then we have pica, right? Posterior inferior cerebellar artery, okay. And then we will have meningeal artery. So this was for the vertebral. Now we talk about ICA. after vertebral, let's talk about basilar. In basilar, what do we have is, first we have is basilar artery. Okay. In this, first we have in the vertebra it was pica, so here it will be ica. Anterior inferior cerebellar artery. So this was the basilar. It was vertebral, now it's basilar. Okay. Then what do you have is superior cerebellar artery. Okay. And then it will be PCA, post cerebellar artery, and then pontine branches, right? And then comes ICA. So this was the 5 things which I told: ACA, MCA, posterior committee, ophthalmic, and anterior choroidal. Now comes cerebellum. Cerebellum, it has, in this it has 6 lobes. Anterior, posterior, we have nodules plus flocculus. So floccular nodular lobe. This is the one which is the smallest. Then we have cerebral cortex and basal ganglia. That cerebral cortex, and in this, when we zoom, we can see deep nuclei, which is when we zoom, we get it, right? Then let's see about cerebral cortex, which is at the outside, right? Outside part. So in this, we have 3 layers and 5 types of cells. 3 layers are and 5 types of cells. Layers are molecular layer, Purkinje layer, granular layer. In molecular layer, we have stellate cell and basket cell. Molecular layer, stellate cell, basket cell. In Purkinje layer, we have Purkinje cells. And granular layer, we have granular cells. Because G, granular cells, one more will be there, Golgi cells. Cerebral cortex is the largest collection of inhibitory neurons. Okay. PYQ also one of the question came about Purkinje layer. And in this, remember one thing, everything will be absent, only remember one, which will be granular layer. Okay. Now, we have 2 things. In the cerebral cortex, if we see, we will have 2 fibers, mossy fibers and climbing fibers. Climbing fibers are the one which will go up till up, right? With no problem. Okay, like olivocerebral tract, para-olivocerebral tract, all these things will be there. But when you have mousy fibers, mousy means it will cannot climb, so it will have some problems. So that's why in this there will be granular cells, right? So then in order to go up, so note is like efferent from cerebellum will be the deep nuclei, and efferent from cerebral cortex will be the what? Purkinje cells, right? So that's how we can see. And we have deep nuclear cerebellum. A doctor eat good food. Okay. So doctor is the one which at the doctor, first of all, is the largest. Okay. And also doctor is the one which is at the lateral. And we have the fastest. Doctor eat good food. Fast ilia is the one which is the medial most, right? And we can see then, and after that, when we go ahead, we can see the lateral ventricle. In this, what all we can see on the above, what we can see, corpus callosum, right? Then comes the medial side. In medial side, what we can see? We can see is septum pellucidum and fornix, right? This we can see. Then is the floor. So in floor, what all things we can see? Floor, we can see caudate nucleus, okay, thalamus striae vein, okay. Then we can see the choroid plexus, and then we can see the thalamus. So these are the things at the floor, right? Corpus callosum at the roof. In the medial wall, we have septum pellucidum and fornix, okay. And at the floor, we can see caudate nucleus, thalamus striae vein, choroid plexus, and thalamus. Then comes sagittal section, third ventricle. So we can see the third ventricle, anterior commissure, lamina terminalis, okay. Posterior, we go to see a pineal gland. Above that is habenular commissure, and then posterior commissure. Then aqueduct we have, posterior above. Then we have roof. A roof, what we have is fornix and choroid plexus. And then we see the floor, okay. In the floor, what we see is optic chiasma, infundibulum, optic chiasma, infundibulum, mammillary body, posterior perforated substance, and tegmentum of midbrain, okay. Let me repeat again. Anterior, what we have, anterior commissure, lamina terminalis, fornix, choroid plexus at the roof. Then pineal gland, habenular commissure, posterior commissure, aqueduct. At the floor, what do you have is optic chiasma, infundibulum, mammillary body, posterior perforated substance, and tegmentum of the midbrain. This is what we can see, right? And then we can see next we can see the transverse section, forceps minor and forceps major. So this was all about the neuroanatomy which I have told, guys. Now I will start with head and neck, right? So in head and neck, let's start by seeing all the cranial fossa. We have anterior, middle, and posterior, right? We have first foramen cecum, then we have cribriform plate, okay. Foramen cecum is the emissary vein, cribriform plate is the cranial number 1. Then we have cranial number 2, that is optic canal, which is also called as ophthalmic artery, cranial number 2. Then we have cranial number 3, 4, not 5, 3, 4, 6 and 5, 1, which will be ophthalmic vein, right? This is there at the superior orbital fissure. Superior orbital fissure, right? Now let's go to more ahead. Then we see foramen rotundum, okay, and then we can see foramen rotundum, foramen ovale, foramen spinosum. So what I told was superior orbital fissure was the 5-1. Then rotundum, ovale, and spinosum. So rotundum and ovale will be 5-2, 5-3. Rotundum 5-2, ovale 5-3, maxillary and mandibular. So first was ophthalmic, maxillary, then mandible. Then we have spinosum. Okay, in spinosum what do we have is spinosum means spinous, so that means nervus spinosus. Okay, in this it will be middle meningeal artery. Okay, that will be epidural hemorrhage. Okay, then we have foramen lacerum. In foramen lacerum it will be internal carotid artery, foramen lacerum. Then what do we have is, so till 5 we were done. Now 7 and 8 it will be internal acoustic meatus, internal acoustic meatus, 7 and 8. Okay, then we have 9, 10 and 11, that will be jugular foramen, 9, 10 and 11. Okay, jugular foramen. Then we have 12. 12 is hypoglossal canal, which is a carotid body. Then we have foramen magnum. In foramen magnum what do we have is medulla oblongata, vertebral artery, spinal artery, and 11th, which is spinal, right? And then in the foramen ovale, it is also called as male because it is 5-3, so that's why we call as mandibular nerve. A means accessory nerve, SI meningeal artery, L means lesser petrosal nerve, E is emissoral vein. Okay, and then we have jugular foramen. In jugular foramen what do we have is, we have 9, 10 and 11, right? 9, 10, 11. So in this it will be what? Inferior petrosal sinus, and at the end will be sigmoid sinus. But 9 will be the one which will be presented separately. 10 and 11 will cause vagoaccessory complex. So let me just say once more: foramen cecum, emissary vein, cribriform plate, cranial number 1. Then we have optic canal, cranial number 2, which will be ophthalmic artery. Then we have superior orbital fissure. Okay, in superior orbital fissure we will have 3, 4, 6. Okay, 3, 4 and 6 and 5 ka 1, right? Superior orbital fissure. Now we have ROS. R is rotundum, ovale and spinosum. And rotundum will be 5-2 maxillary, and ovale will be 5-3 mandibular. Okay, then we have spinosum. Spinosum middle meningeal artery, foramen lacerum, which is internal carotid artery. Then will be internal acoustic meatus, that will be 7 and 8. 7 and 8, right? Internal acoustic meatus. Then we have jugular foramen. In jugular foramen it will be like 9, 10 and 11. 9, 10, 11. So in 9 it was present separately. 10 and 11 will be vasoaccessory complex, right? Then we have hypoglossal nerve, which will be 12. Okay, jugular foramen 9, 10, 11. Internal acoustic meatus this, and then this, then magnum, foramen magnum. And about ovale we told as male. Okay, jugular foramen I told. So this was done. Now you all need to identify it. So now what's pterion? Pterion is the one which has deep relations. Okay, so it has 4 deep relations. First is frontal, then it is parietal, then it is squamous part of temporal bone, and then we have greater wing of sphenoid. So this is the one which is like we can see frontal, parietal, squamous part of temporal bone, and greater wing of sphenoid. Now let's see the deep relations. Anterior or frontal division of MMA, middle meningeal artery, first thing. Then lateral sulcus or sylvian fissure. Okay, lateral sulcus or sylvian fissure. Third will be middle cerebral vessel. Fourth will be lesser wing of sphenoid. So in pterion it will be epidural hemorrhage, right? Then we have superior orbital fissure, foramen rotundum and pterygoid canal. Okay, and also we can see like by seeing frontal zygomatic bone. Okay, then we have ethmoid bone, then we have lacrimal bone, and then we have maxilla bone. This all are of orbit. Now let's see the muscles of mastication. In mastication what do we have is masseter muscle, this is M. Then what we have seen, we elevation and retraction. So then we have temporalis muscle. In this it will be elevation and retraction, but I think elevation will be more than the retraction, right? Then comes the main, which is buccinator muscle. Okay, in buccal muscle, what do we have is we have accessory muscle. In this, we have lateral and we have medial. Okay, lateral pterygoid and medial pterygoid. So, in the lateral pterygoid muscle, what is there? Lateral pterygoid means depression of mandible or opening of the jaw. Whenever you want to open the jaw, what do you need? You need lateral muscle. Okay, and whenever you need to the most common muscle which is involved in trismus, which is locked jaw, that will be medial. So if you want to open, you need only lateral, right? Okay, then you have muscles of mastication. It will be what? Mandibular nerve, which will be 5-3. Retraction of the mandible. Whenever you want to retract the mandible, then you need what? You need temporalis muscle. Okay, retraction of the muscle, elevation will be more, but retraction will be temporalis muscle, right? Then we have accessory muscles. Accessory muscle is used for what? Accessory muscle is used for buccinator. So temporalis muscle is for this. Buccinator is accessory muscle. Okay, lateral is the one which needs the opening of the jaw. Mandible is mandible for the closed, right? Okay, so now you have 4 things like muscle of tongues. So in the extensive muscle, we have 4 things. First is the genioglossus. This is the largest. This is the safest. It prevents tongue from falling back. So genioglossus is the one which is very important. Then we have palate, hyoid, and styloglossus. So in palate, what do we have is palatoglossus. Okay, so this is not a true muscle. Okay, so genioglossus, then above will be palatoglossus, then we go side, then it will be styloglossus, and down will be the hyoglossus. So question is, the patient is asked for protrude the tongue, and tongue deviates to paralyzed side. So which will be the nerve? So that will be hypoglossus nerve, right? Okay, so now comes the important part of the tongue. We have motor and sensory. Motor means all part of the tongue will be supplied by 12, except palatoglossus. Why palatoglossus? Because palatoglossus is the one which will be supplied by vagoaccessory complex, right? Okay, so now we have 2 things. Anterior 2/3 of the tongue. In tongue we have 2 things. It will be spatial and it will be general. Okay, spatial is the one, and this there will be first is anterior, and then we have posterior 1/3, anterior 2/3, posterior 1/3. So 5, 7, 9, 9, 10, 10. 5 is the one which is spatial. 7 is the one which is 5 is the one. See, 5 is just a normal number, so this will be the general. S is the one which is spatial. 7. Okay, 7 is the spatial. Then we have 9, 9, and 10, 10. So in the spatial one, what do we have? In spatial one, we have CT. Okay. See, general is always general. General is what? It's a lingual branch, then mandibular branch, which is V3, and then trigeminal nerve. Okay. But whenever you are spatial is 7. 7 is spatial means CT. S for 7, S for CT. So spatial will be 7, then it will be CT, and that will be facial nerve. Okay. 7 is facial nerve, spatial and CT, and general will be lingual and mandibular nerve, right? So this is the main. Now you can talk if you want to. Like we have fifth nerve. In fifth, what it will be? Trigeminal nuclei. We have V1, V2, V3, ophthalmic, maxillary, mandibular. Okay. In this, what we can see is great auricular nerve. Okay. So sensory supply to the face, fifth nerve, except one, which will be skin over mandible, right? Great auricular nerve. So after this fifth nerve, trigeminal nerve, we have to see the seventh one. Seventh seems to be very important, right? Because in seventh it will be 3 things. It will go to interacoustic meatus, then middle ear, and then zygomatic and face one, right? So in the interacoustic meatus, it will go to greater petrosal nerve, and then it will go to eye. Okay, then it will be pterygopalatine ganglion. Second will be middle ear, and when it will go to ear, and then third will be face. So first we go to face. We have face 5 things: temporal, zygomatic, buccal, marginal, and cervical. So when you have 5 things, it will be face of muscle of facial expression, except nerve number 3. Okay. So then we go to middle ear. In middle ear we have what? It will go to chorda tympani. It will provide to the anterior 2/3 part of tongue, which will be mandibular and sublingual. Okay. Then same stapedial muscle. It will through internal cavity. It will go to nerve to pterygoid canal, which is also called as Vidian nerves. Okay. Then it will go to eye through pterygopalatine. Okay. So upper motor and lower motor, this we can see. Okay. And then comes the 8th nerve, which is vestibulocochlear nerve, auditory pathway. So we all know echolemma. Okay, and echolemma is what? First we can see the in this it will be inner ear, outer ear. So it will go to spinal ganglion. Then it will go to colemma. Colemma is second. Second is cochlear nerve. Third is O. O is superior olivary nucleus. Then we have fourth. Fourth is inferior. Third is what? Third is superior olivary nucleus. Okay. Fourth one is L. L means lateral lemniscus. Okay. Then we have five. Fifth is I. I is inferior colliculus. Then we have M. M is what? Medial geniculate. Okay. Then we have A. A is auditory area, 40 and 42. And then we have another, it will also be auditory radiation, right? Then glossopharyngeal nerve, which is ninth. Glossopharyngeal nerve is what? In this, it will be Jacob's nerve. It will go to pharynx. Okay, it will go to carotid sinus and also to the tongue. So first, it will go to where sinus, extra carotid, internal carotid, common carotid. Okay. Then second, it will go to where? It will go to middle ear. Okay, otic ganglion and parotid gland. Third, it will go to pharynx, stylopharynx. And fourth, it will go to general and spatial sensory of posterior part of 1/3. So anterior part was where? In the facial nerve. And the ninth one, which is glossopharyngeal, it will go to posterior part, right? Then comes vagus, 10th nerve. It will go to where? It has 2-3 things. So first of all, it will go to recurrent laryngeal nerves, all muscles supply recurrent laryngeal nerve except cricothyroid. Then it will have a mucosa of larynx, below vocal cord, then a muscle of pharynx. Okay. Then it was the first. Second, where it will go? It will go to internal carotid. Okay. First it will go to carotid, cricothyroid muscle. Okay. And then it will go to hyoid. Then fourth, it will be SLN, right? Then it was the 10th and 11th where it will go? Vagovocal complex, and it will go to pharynx and palate. But pharynx except what? Stylopharynx and cricopharynx, and palate everything except TVP, right? So now we can see the 11th nerve. It will go to where? Sternocleidomastoid, trapezius muscle. Okay, 11th one. And this is also question of January 24. Dropped shoulder. Then we can see 12th nerve, hypoglossal. It will go to sternothyroid, sternohyoid, omohyoid, and it will go to genohyoid and thyrohyoid muscle, all muscle of tongue except PG, pharyngeal complex. Okay. So now I have told you all the nerves. Okay. Now let's go to neck. In neck, what do we have is, we have investing layer, we have pretracheal layer, we have carotid sheath and prevertebral fascia. Okay. Investing, pretracheal, carotid, prevertebral fascia. And then when we see here the structures, what we can see is, first we can see the 10th nerve. Okay, this is the 10th nerve, and then we can see the sympathetic trunk. This is important, 10th nerve, sympathetic trunk. Third, what we can see is the recurrent laryngeal nerve. Okay, and recurrent laryngeal nerve. And then what we can see, the important one, which is phrenic nerve. Okay, recurrent laryngeal nerve. Then we have phrenic nerve, which will be C3, C4, C5. Then what do we have is, we have brachial plexus. So these are the things. Now when we can see the sagittal section of neck, what we can see here is buccopharyngeal fascia. Then we have retropharyngeal fascia. Then we have alar fascia. And this is the most important, is the danger space. Then we have prevertebral fascia. First is buccal, then retropharyngeal, then alar fascia, then danger, and then prevertebral, right? Now we have carotid sheath. So in carotid sheath, what we have to see? We have to see the contents. Okay, anterior wall, posterior wall. This contents are important, in which there will be no external, right? Only CCA, common carotid, ICA, IJV, and vagus nerve. These are the 4 things, right? Then we have dura venous sinus. In this, what we can see is, first we can see superior sagittal sinus. Okay, from here we can see occipital sinus. Then we can see the straight sinus. All 3 of them will form confluences of sinuses. Okay, then it will go ahead through jugular foramen. Okay, 9, 10, 11. Then it will form inferior jugular vein, that will be inferior petrosal sinus. Okay, then straight sinus, it will go ahead through inferior sagittal sinus, and then it will form this great central vein of Galen, continuous straight sinus, right? So this we can see, this we have seen. Now we have cavernous sinus. In cavernous sinus, this passes through lateral wall of cavernous sinus. 3, 4, and 6. 3, 4, and 6 will be through cavernous sinus, and then this passes through the cavernous sinuses, which is ICA and sixth nerve. Then you have pulsatile exophthalmos, ICA. Okay, in this it will be cavernous sinus pulsate through ICA, which will be pulsatile exophthalmos. Okay, then we can see triangle of neck. So in the triangle of neck, what do we have? Yeah, main C. Let's see the boundaries. In boundaries we have SCM. Okay, then we have trapezius, and then we have clavicle. SCM, trapezius, clavicle. These are the three things. So these are the boundaries. Okay. Yeah. So now let's see in this what all we have to know is greater auricular nerve we can see. Okay, and then behind what we can see is 11th nerve, trapezius nerve, shrugging. Okay, and greater auricular nerve, this is important. It just run along external jugular vein, skin over mandible, lobular of ear. Okay, loss of sensation in shaving area. Then as Fraze syndrome, this is very important because this regenerate auricular temporal nerve, most commonly joined with great auricular nerve. Okay, so this is the great auricular nerve. So this joins between the two auricular temporal and great auricular nerve. So this means Fraze syndrome. Okay, which leads to gustatory sweating. Okay, then we have triangles, digastric triangle, submental, carotid, muscular. We can see. Okay, and then what we can see in subclavian, we can see scalene anterior muscle. First part what we have is vertebral artery internal width. First, second, third. First is width. In width it will be sit. Then we will have second and third. Okay, width is what? Vertebral artery internal thoracic, thyrocervical. In T we have sit. Sit is suprascapular, infrathyroid, transverse cervical. Second part we have costocervical. Third is dorsoscapular. Okay, and then we can see the structures, and we can see external carotid, facial artery, and maxillary artery. So these are the three which we must know. Okay, in this we can see EEC, it's a branch of, then we have some of the branches. Superior thyroid, lingual, facial, all these things we can see. In the facial artery also we can see. In neck we have stack, submental, tonsillar. Then maxillary artery we can see maida, first part, then second part and third part. All these things we can see the parts. Okay, and then comes the veins of face, supratemporal vein, maxillary vein. Okay, so this is for IJV and EJV. So now let's see the parotid gland, and in the parotid gland we can see facial nerve, external carotid, and retromandibular. Okay, so parotid duct open where? Upper second molar. Okay, rest two submandibular lingual, these all are at the floor of the mouth. Parotid at upper second molar. Now let's see the pharynx. This is important. Pharynx and larynx we will see. We have two muscles, longitudinal and circular, right? So in longitudinal we have stylopalatossalpingo. Stylopalatossalpingo. This is the longitudinal muscle. Then circular we have superior constrictor, middle constrictor, and inferior constrictor. These are the three things. In inferior we have TP and CP, right? Then we have cilian dehiscens. In cilian dehiscens we have what? Pharyngeal muscle. Okay, thyropharyngeus and cricopharyngeus. So stylopalatossalpingo, these were longitudinal. Superior, middle, and inferior, that will be circular muscle. Then we have larynx. In larynx we have 3 unpaired and 3 paired. This we know, I think. In unpaired we have thyroid, cricoid, epiglottis. In paired we have aragonite, corniculate, and cuneiform. So these are all the things. In muscle of larynx we can know two things: abduction and adduction. In abduction means AB. In this there will be post-cricoarytenoid muscle, which is safety muscle of larynx. Okay. In adduction it will be lateral cricoarytenoid muscle. Okay. So your this chapter is also done. So we will talk about next chapter.